This is the first time in my life, and I don't know whether I can send it to Guinness Book of Records, that in the same meeting I gave two talks, first and the last talk. I have done some in IPS, annual conference, where from one parallel session where no one was listening to me, then I go to another parallel session where again there is nobody listening to me, and here I have such a nice group of people, and one of them is still on ChatGPT. He is asking that question whether ChatGPT can marry or not. Yes. And it's very strange, a strange feeling. When I started, I'm getting ideas of reference that you are all watching me. So when I started, it was, what is he going to say? And now it is, when is he going to end? So that they've started preparing for the lunch. Well, okay. So psychiatry, now this part of the talk is actually optional. There are many roles of psychiatrist which we have talked till now. When I talked about disorders, and Dr. Joyita talked about psychopharmacology, Dr. Savita talked about survivors and all. Now these are other parts of palliative care and oncology, which is only people who are little more interested or specialized should do. It's not for everyone, because this is what I'm going to talk about. Now, when we talk about psycho-oncology, it's only one branch of medicine that we are talking about. Now, similar phenomena, so there are multiple roles, like I said, we'll talk about some of these, but there are similar things in other fields of medicine. Psycho-oncology, and this is sometimes I do like a quiz. What is psycho-oncology? I ask if there are residents. Psycho-nephrology. Incidentally, in 1986, I attended my first psycho conferences. I attended a psycho-nephrology conference, and I went to Memorial Sloan Kettering and spent some time, many weeks there, with Jimmy Holland on psycho-oncology. That was the first time I heard the word psycho-oncology, and they had a psycho-oncology service there at that time. So I asked people, and this is like a catch question. So psychocardiology, and incidentally, I have written about most of these, because I have been looking after consultation liaison psychiatry at NIMHANS. Psychogynecology, all this women's mental health. Psycho-ophthalmology, I've written a few reviews on this. Psychosomatic or ENT, psychodermatology, and Dr. Shobha and to BPS, I'm giving you ideas. Next time you can have conferences on all of these. Like you're having psycho-oncology, you can have psychonephrology, psychocardiology. Then comes psychosurgery. Anyone, what is psychosurgery? Yeah, you invariably I get the answer saying studying psychological aspects of surgery. That's like, and what is orthopsychiatry? And people say it's about orthopedic disorders, but it's not orthopsychiatry, it's not that. Orthopsychiatry is study of personality and psychological dynamics, psychodynamics. So this was in 40s and 50s and 60s. Orthopsychiatry was a big branch, and now after, the Freudian things have gone, it has all disappeared. Then psychotherapy is obviously, we all know, psychosomatic. Psychoneuroimmunoendocrinology is again related to psycho-oncology, because when we talk about stress and cancer, we explain them on the basis of psychoneuroimmunoendocrinology. Psychopathology is, of course, nothing to do with pathology. And psychopathology is neologism coined by me. It is about the preoccupation with bathing. When we see psychiatric patients, and a person has become, PANSS score is nil, and they've got no psychotic symptoms, and we are feeling very happy, and the relatives say, "It's not, abhi theek nahi hua." Kya hua? Nahata nahi hai. So there is that preoccupation with bathing, and then of course psycho. Psycho is just psycho. I'm talking about psycho movie, Psycho 1, Psycho 2. So there are a whole lot of other psycho terms which come. So the incoming president of BPS and the outgoing, you still have time. You can do many more meetings on many of these topics. So when I said why are we talking about all this? It's okay, treatment of disorders and various other things. But can quality of life be changed by psychiatrists and mental health professionals? When I say psychiatrists, I obviously mean all psychiatrists, psychologists, social workers, mental health professionals, because the area of work is very, very overlapping. So there are a lot of roles. That's why I said it's optional. It's not for all psychiatrists to do it or all psycho-oncologists to do it, but if they prefer, they can do it. So it can be done through surgery, because one involves in communication and counseling regarding making choices, informing about reconstructive techniques, microvascular techniques, rebuilding soft tissues, and use of prosthetic and care of colostomies. A whole lot of these do not require only a physician or a nurse. It requires also some mental health, emotional, psychosocial intervention. Similarly, for RT, giving information, how to reduce skin marking, how to, talk about RT. So it's about helping people make decisions, reducing myths about RT, and educating, which helps maintaining quality of life. Some of these things I've already talked about, like anticipatory nausea and vomiting, where there is a need for relaxation exercises, deconditioning, systematic desensitization, helping people with their body image, with the use of wigs, reassurance, helping with financial stress, with financial support and financial guidance, or with pain relief, symptom relief. Many of these things we have talked about. Rehabilitation, marital, sexual counseling, and this discussion we were having about survivors, marrying survivors, and whether their marriage is success or not. That is another topic you can have on what is a successful marriage, and you can have a lot of debate and talk on that also. So financial support and advice, and also lastly pastoral, religious and spiritual help. So the therapies along with psychopharmacology are called adjuvant psychological treatments. A whole lot of things which we have discussed. And incidentally, this is something very interesting, because I did a lot of studies on quality of life. And just assessing quality of life improves the quality of life of a person. It itself is therapeutic. These are things which nobody has talked to them about. How are you coping? How are you dealing with? How is your personal life? How is your financial life? Everyone talks about where is the disease spreading? How much is the disease spreading? Is it responding? Is it not responding? Is there pain? Is there no pain? Nobody talks about the other parts of life. And effective communication skills, including breaking bad news. So this is not so important for this group here. There are many models of breaking bad news. I started searching, I found a whole lot of them. But I think we inherently have our own clinical method of breaking bad news, and one should follow that. So why is good communication skills important for clinical care? For the patient, of course, like the things we talked about in the morning, earlier in the morning, reducing fear and anxiety, assist in sorting out complex information, reduce uncertainty. Now, most important part of communication skill is talking to people about how to deal with uncertainty. And we talked about so many things in the last few discussions. But we should know that there is still no perfect answer for any situation. It's always might be, maybe, perhaps. In some this happens, in some this doesn't happen. In whom what happens is what we don't know. Even for that we have prognostic indicators, but we don't know exactly. We cannot predict with certainty. So enhance the sense of control and allow patients to discuss concerns and promote psychological assessment. But the most important thing here is, in the end, when we talk about ethical practice, it's about autonomy, helping people make informed decisions, increase patient satisfaction, increase compliance. But the last thing, reduce stress and burnout. And when Joyita was mentioning about talking to oncologists, that is where our strength is. Just ask them. They feel so unnerved. Ask them, how have you been? How are you coping with all this? You know, what do oncologists see much more than us? They see mortality and morbidity day in and day out. In palliative care, imagine, they see more than one death every day. They see such advanced, they don't know next day the person will be there or not. So this is, you know, they don't know how to deal with this. They go back with that. It leads to staff stress and burnout amongst doctors, nurses, all the staff that they have. And they don't know. And then when you give them a warning shot, you can talk to me. And that is how you develop a good collaboration, a good association, a relationship. You know, it's not only you helping them, you are helping yourself also when you talk about stress and burnout. So staff stress and burnout among professionals is, in looking after them. When you do a systematic review on communication skills, and it shows that it probably improves patient satisfaction, but that is not very definite. It improves decision making, maybe that's not definite. One thing which stands out is having good communication skills reduces your stress and burnout. You know? So when I do sessions with palliative care physicians and oncologists, I always tell them, have good communication skills for yourself. Because you will go back and sleep well. Instead of this thought obsessively roaming on in your mind, did I do the right thing? Did I say the right thing? Did I upset someone? And there you are, having a sleepless night. So you do it in a scientific way, you do it in a professional way, you do it in a way which helps you as well as your patients. So the stress and burnout, of course, problems of communication, relationships stands at the top. Difficulty in taking conflicting decisions. I mean, we are much more used to not deciding for anyone. Many other physicians, they want to decide. Patient says, give me this. They say, okay, take this. If they say, you take this, we'll say, oh, what do you want? Here maybe it's not so much, but when we practice in UK, and giving an example of a person you want to treat for depression, you ask them, which antidepressant do you want? Because the bottom of it, all antidepressants are equally effective. It's a side effect profile which is different. So somebody wants sedation, somebody wants appetite, somebody wants activity, somebody doesn't want sedation. Whatever you want, you will be able to help. It's not that you take Prodep. Even sometimes some doctors will say, even the name of the brand, you take Prodep or you take Prozac. So you don't have to, So breaking bad news, like I said, work overload. The same work looks much more. And like I said, admission of dying patients. So this is again very optional. And this is about spirituality, which automatically comes in palliative care, in oncology, and everywhere. We all have a spiritual element in us. Now that I am, after retirement, I'm doing seva in a spiritual hospital or Chikitsalaya. And there are certain things I have started believing, much more than I believed earlier. I feel that everything is predestined. I was destined to meet you all today here. You were all destined to be with each other here. And you might not realize it now, but maybe after 1 week, 1 month, 1 year, 2 years, 5 years, and you'll remember, oh, that day we had this discussion about ChatGPT, which Dr. Wahia mentioned, or we talked about this and we talked about that. Something makes sense much later in life. So I'm trying hard not to drift into sound like a guru or a sant, So, but these are things. And this is not only in Bhagavad Gita, this is Freud also said, to make it, in his psychodynamic things, that you like people whom you have met before. Or you are likely to meet people whom you have a liking to or attachment to. You are likely to meet such people. What it means is that probably those are the things which you will probably stay in your mind. So So spiritual issues during cancer care are at every stage, right from breaking bad news till end of life in palliative care. They are raised by survivors, caregivers, and raised by professionals. What am I doing? Why am I doing this? Why am I, working with people? Why am I? They get very attached. Somebody has a name which is similar to somebody in their family. Some child looks like somebody else in their family. Then we make connections automatically. See, either because of practice or naturally, if you believe that you have all selected psychiatry, psychology because of some inherent thing in you, we make associations, we make attachments, we always look at people's feelings, people thoughts and cognitions and various things and behaviors, So during end of life, now this is what, like I said, it's not obligatory that everyone has to do that. But if you are involved in consultation liaison psychiatry, these are the questions you will be faced. Am I dying? How will death be? Will I suffer during dying? Should I pray? Should I not pray? People expect responses from you. What will happen to my body? What will happen to my soul? What will happen to my family and relatives? That is the easy part. That you can tell them, but many other things. Will I have a good death? What is a good death? In most workshops, I ask people, what is a good death? What will be a good, how would you like to die? Ask them, So they should be prepared. We have to be prepared with this, talking about thanatos. And thanatosis is the preoccupation with death. So most people who deal with patients with advanced disease have thanoptosis. They are all the time preoccupied with death. Not their own, but somebody's or the others. But that thought will sometimes come to you. Why not me? Why me? But why not? Can it be me in this position? This person was all right yesterday. Today is, advanced disease. So many things have been detected. I'm very lucky I'm not in his position. So get used to death, and you're going to see a lot more if you're going to be in these things. So many spiritual issues come up. Dealing with why me, I think Savita had alluded to that about why me. Why me is the most difficult question. In communication skills, we are all very familiar. I tell people, never ask why. Why is a difficult question to answer. So what happens to you, somebody sees, person says, I'm feeling sad and depressed. Why? I'm feeling very nervous. Why? Oh, why, if we knew why, they would not come to you. Isn't it? So why is a blocking question in communication skills. Never ask why. Ask what, ask when, ask where, ask what happened, ask how. Don't ask why. But patients are allowed to ask why, and that is a very difficult question. Why me is a question which doesn't have an answer. We can speculate. We can say risk factors, we can say probabilities, we can say, but we still can't explain everything. But why me is a very good question, because we need to listen to the response. That allows the person to introspect, think about why have I got a disease, what did I do, is it my karma, is it my fate, is it something I do in earlier life, is there something, it's helping me with something. So we consider why me as a spiritual question or a philosophical question, and where you need to sit and encourage the person to speak and talk and express their feelings. In the end, they have to find their own answer. We don't know. And we'll never know. So why me is a spiritual or philosophical question. So we talk about strategies of handling difficult questions, where we talk about never answer a question. I tell them, use a psychiatrist or a psychologist approach. Never answer a question directly. If they ask you a question, reflect that. What makes you ask that? What do you think is the answer? And maybe they'll make your job easier. They'll say, yeah, this is what I say, yeah, I also think the same. So I tell them, never answer a question directly. But then I tell them there are two contraindications. Never do that in a viva. Why when they ask you, what is thought broadcast? You say, what do you think is thought broadcast? Then you have to come back again 6 months later. So, other than that, and so the second contradiction is your boss. Never question your boss. Boss is always right. So never ask, never reflect a question there, but you can reflect a question. It's a very, very good strategy. And some of these things, it's there in our history-taking practice and assessments. We always do it. So, but many other physicians don't, because they are so very preoccupied with their thing. So, ask open-ended questions. Be non-judgmental, very important. This is very important. Don't let your thoughts and feelings and spirituality be forced onto them. Always, if there is a time, they should check about, do they have any religious or spiritual beliefs which provide comfort? Do you have peace of mind? Is the most important factor in quality of life. So when we talk about, marital, successful marriage, so is successful marriage with a BMW or with an apartment or with peace of mind? Different people have different views on that. So there have been barriers, to communication. Dr. Shubha, maybe you can share my slides so people who are interested can take these and read it. I will not go into more details of that. So there are various domains about spirituality is something which I have been preoccupied with much more recently, and look at spirituality in a number of things. Spiritual counseling is again a specialized way of counseling, which is listening to the patient's inner spirit and soul and things like those. Again, spiritual support, complementary and alternative medicine provides that. Certain issues which at the end of life are like spiritual pain, spiritual distress, which Savita had shown, spiritual concerns, and having a spirituality quotient. Spirituality quotient is there, we all have, like an IQ, we have a SQ, not a social quotient, a spirituality quotient, our spiritual weaknesses and strengths, and how to improve that. So people can do spiritual assessment, like I said, optional. You would like to take up spiritual history. There is something called as spiritual milestones. Many times people think that spiritual milestones comes with age. So it will come to me at my age. But we all know, we have seen enough people as adolescents who have a lot of spirituality. In Vrindavan, I see a lot of youngsters. People who are under 10 have such high spirituality. And adolescents, of course, quite a lot. So it is there at many times, and everyone has different spiritual milestones in their life. There's nothing to do with so much to age. If you get into it, we should all have like a cultural competence. We should have a spiritual competence and be able to talk about it. There are many attributes which reflect spirituality, attachment, detachment. Like I said, I don't want to, sound like a guru, but have faith. Accept reality and with reconciliation, find the meaning of your life. I find Viktor Frankl's Man's Search for Meaning as one of the most important book, which talks about helping people understand suffering. If you can understand the meaning behind your suffering, suffering doesn't remain a suffering. So encourage people to do that. Spiritual treatments, if it is possible, as I mentioned, spiritual care and support. Training in spiritual aspects is very important part of oncology. So in psychiatric oncology, people talk about these things. Many of these you don't have to answer. You just have to sit quietly and listen and encourage them to elaborate on that. So I feel there are many places in our country where there is spirituality is in the air, like in Varanasi, Ayodhya, Vrindavan, and maybe in similar places in Christianity and Islam, where there is spirituality in the air. When you go there, you feel a different sense, very difficult to describe. And there's a spirituality in the air. And but we, in the end, look at spiritual, good quality of life, satisfaction with attachments, spiritual satisfaction, and look for Santosh, the spiritual satisfaction. If you have Santosh in your life, that's, huh? Well, thank you very much. I wanted somebody to say that. Has spiritual satisfaction is probably a very important part of practice and life. And with this, last part is grief and bereavement. But to this group, I really don't need to talk about it because we do grief therapies, grief assessments and others. But in palliative care in advanced cancers, it's much more common, much more frequent, and we need to help people, the survivors who would be going through grief. So there are grief supervision groups. They have anniversaries and anniversary reactions, so we need to train doctors regarding grief and bereavement. Physicians are very inapt at it, so we need to encourage them to be able to do that. Thank you very much, and I hope try to cover as much as possible in as short a time.
It's a very interesting subject, and probably all of us need to know more about spirituality, not at an old age, but at a young age. And religion plays an important role in psychotherapy, and we should know the principles of all the different religions, because we get patients from all the types of religion or a background. There is something more about the cancer survivor, and I knew about a professor of surgery from Nair Hospital, Dr. Rishikesh Buch, where in second or third MBBS he got a cancer of urinary bladder extending to the colon, and bladder and rectum both were removed, and then he had a bag here. He, after doing his MBBS and MS here, he went to England, did his FRCS, came back as a professor at Nair Hospital, and all throughout his life, he treated patients, and then he specialized in actually how the bag should be put in which place and how to look after it. And he wrote a book on this and continued his work all throughout his life. Last year he died with the infection, but he survived, and he was an example where people did not know that all throughout his career he had survived and he had helped people. And this sort of a dedication came, and he used to tell, if I was not sick, probably my life would have been different. But he did the work all throughout. And this is an example that some people who have suffered themselves, like in psychiatry we say, if we have suffered little neurosis, we would be a better psychiatrist to help other neurotic patients, not psychotic. So, this way probably the good examples and Sir's now spiritual appearance and spiritual treatments are probably the best thing to do at the palliative care therapy. And thank you very much, sir.
Thank you, sir. Your chat GPT, what is it saying, Dr. Vaya? I'm now scared of him.
I don't know about GPT, but my question is, why are all religions punitive? Why do they keep threatening people? If you don't follow spiritual diktats, you will be punished. Why don't the religions encourage people to follow religion for its positivity? Why the punitive measures?
Yeah, I fully agree with you. They should not.
That's how they work, sir. They work on fear.
It's because it's made by men.
Yeah.
God did not make it.
Yeah, that's right. Yeah. And the, yeah.
Sir, I'm Dr. Rupinder Gill. I'm a psychiatrist from Navi Mumbai. I had a small query for you, sir. So regarding capacity assessment for patients refusing treatment, so could you shed some light on it, sir?
About capacity assessment?
Yes, sir.
In,
Patients suffering with cancer for the...
well, it's probably the same for anything. Capacity assessment is capacity assessment for
Sorry,
anyone.
sir, I would say capacity assessment is only for MHCA, only for mental illness. In other cases, patient's refusal is not applicable. MHCA is only applicable to mental illness, full stop.
No, sir. I mean, I think for any decision making, capacity is very important. And it might be a person with any disease, or it might be a person without any disease also, you know. Even if you have to write a will, you know, you have to do a capacity assessment. And, yeah. So it's very simple if you want to put it. There are scales, but I don't want to confuse with that. Of course, you might be knowing them. It's the bottom line is whether the person can understand what you are saying and they can show that they have understood, and you can make an assessment that yes, they have comprehended what I have said, they have understood what I have said, and then they are in a right position to make a decision. That's a capacity.
I don't usually write the word
Yeah,
capacity.
yeah, we don't need to.
Because I don't think it's capacity and competence, and then it is all that fitness thing which comes in, which has nothing to do with me. So it is just to say that we have spoken, we discussed with the patient and caregiver, patient understands treatment, patient understands consequences of
Yeah.
treatment, patient understands whatever, if you don't take treatment, what will happen. But because it is best to make it that the patient needs to make the decision. Otherwise, it's just kept on us as the psychiatrist, you say whether patient can undergo treatment. Nothing like that. So out of 10 times you write patient, then they get the idea that it is patient.
Thank you, sir.
We just complicate our own lives. Psychiatrists complicate their own lives by doing all this. So you need to think on the other perspective, other person's perspective as to why they are asking. One is we are extremely prickly, and it is like, how dare they ask us questions? That will not do. Second is you understand why they are asking the question. And third is you have to be friendly but firm and say this is it. But we are also very prickly.
Sometimes I would feel, why are they not asking questions? Do they think I'm incompetent? They're not asking questions. I like questions. So I like your question. So I like others also to ask questions.
And
But
liaison psychiatry is all about making, sort of friendships with the whoever you are liaisoning with. Liaison psychiatry, we cannot sit in our ivory tower and do that. We have to get in the field work and talk to them at every level. The residents ka kya hai, consultants ka kya hai, why are they asking? And consultants will just tell the residents, find out where on the is and get to this thing and bring her up and this, and the residents will call. But I think if we talk about liaison psychiatry, it's all about making those friendships. And then I have a difference of opinion with Dave, sir. I think as far as theory is concerned, they say spirituality should be, taken separately from religion. But I understand, and that is my always talking to the international people, we don't really have any choice of our religion. None of the religions allow us to say, no, I will not. I'm still that religion. Whether I practice it or not is not. So much of our spirituality in our country, I think, is invested in religion. And much of our spiritual practices may be religious practices, and much of our religious practices can be spiritual, which sometimes is very difficult. I'm sure sir has met this concept before. It's very difficult to make our palliative medicine physicians understand the concept.
I try to simplify them. Everything religious is spiritual, but everything spiritual is not wrong. Because there are atheists also, but I go more by the psychiatric dynamic concepts of meaning in life, meaning of existence, meaning which has nothing to do with religion. So,
I think that's a very safe question to say. What is your meaning and purpose in life?
more you think, the more you will realize. I think so.
No, but that's also because we make it such an esoteric concept, that spirituality is something and, that way. But it is not, right? Simple things that you would do and to find meaning. And simple everyday things that you do is where we find our own spirituality. And, yeah.
I just wanted to ask one last question. Are there times in consultation liaison where we feel that we are just being used to do the work which they offer? Unnecessary references that you think if a person is referring, okay, refer to psychiatry, they'll explain. If the person is not giving consent, okay, refer to psychiatry, the person is not giving consent.
Yeah, but then aren't we the best persons to do that? They are obviously not the best persons to do that. So at least they are thinking of us that we can do this. So I think it's very laudable that they have been asked and they No. So then I have two examples. One was one of the beginning things when I came, one of the referrals was a counsel for amputation. So I said, I'm sorry, I'm not the one going to do the amputation, so I haven't tell them that they're going to do, but please don't. So then that stopped. Then the other one was the famous psycho came in. It was referral for psycho opinion. So I said, sorry, I am not a psycho, I am not going to give the opinion. Write down properly and then give me. So we have to push back at different times, but I think it is...
I think the attitude to consultation here as psychiatry differs drastically in public hospital and private hospital.
Yeah.
In public, you feel they are pushing. In private, good welcome.
No, I will.
Private, actually, they have got to give this is only one time consideration, don't come again and again.
But look at it this way. It's they have realized that they are not competent for certain things. And again, they have it. It's not everyone.
शोभा जी चलो खाना खाते हैं.
So we wind up after this very interesting, thought-provoking session today. I would like to thank, on behalf of Bombay Psychiatric Society, all our three esteemed speakers, and to do the honors of a small felicitation, may I invite all the three senior psychiatrists here to please come forward. Ambedkar sir, Dave sir, and Mahia sir. And
Ask ChatGPT.
Chaturvedi sir. They couldn't take proper photos.
We'll ask ChatGPT.
Thank you.
Thank you very much.
Discussion can continue with lunch.